on physical activity and sedentary behaviour after stroke, how much, when, and the impact on recovery and long-term health. Coralie currently leads a team of researchers whose work focuses on understanding the effects of physical activity, aerobic exercise, and sedentary behaviours in people after stroke. She is an experienced physio-clinician, having worked for many years predominantly in the area of stroke and neurological rehabilitation prior to commencing her research career. Coralie's earlier research work is well known and focused on the methods of increasing therapy time and active task practice for stroke survivors receiving in-hospital rehabilitation, including the use of circuit class therapy and 7-day-week therapy services. She's also the co-chair of the Content Development Working Group for the recently updated Clinical Guidelines for Stroke. We expect this webinar to run for around 60 minutes, and there will be time for questions at the end of the presentation. However, please feel free to ask questions throughout the presentations via the online platform. At the end, a short survey will appear on the screen, which should take less than a minute to complete. All responses remain anonymous and greatly assist the network to design future webinars to suit your needs. So on behalf of the VSCN, I hope you enjoy this webinar, and I'll hand over to Coralie to begin.
Thanks, Edwina. I'm hoping everybody can hear me. Can you hear me at least, Edwina?
Yes, we can hear you.
Okay, good. So we're going to assume that everybody else can hear me for now. Thank you very much for inviting me. I do have to say it does always feel a little strange. I'm standing here in my office. At least I've got a sit-stand desk, which you'll all be rushing out and buying after this presentation, by the way, if you haven't already. So at least I am standing up and feeling like I'm presenting, but I am looking at the window at the lovely sunshine that we have in Newcastle today. So thanks very much for coming, and I hope in this webinar to give you a bit of an overview of the topic around physical activity and sedentary behaviour and activity and how physical activity can drive recovery after stroke. So I've sort of pitched it as an overview sort of session, covering off on some of the guidelines and the evidence behind some of the recommendations in the guidelines in this space, as well as telling you a little bit about my past research and future research. So hopefully there'll be some information there that's of interest to you, and we'll be happy to go into more detail about anything in particular towards the end. I can see questions, so if there are any burning questions that come up, I may be able to keep an eye on them and answer them as they come up. Otherwise, we can have a robust discussion at the end. So, getting my computer going with the clicks. Okay. So I'm going to start with a bigger picture around the guidelines. So as Edwina pointed out, I was heavily involved in the development of the updated stroke clinical guidelines, particularly from the rehab and recovery perspective. So Bruce Campbell and I were co-chaired the content development. So of course, Bruce being the acute neurologist down there was focused much more on the acute stuff, and I oversaw much of the others. I wanted to remind people, I'm sure everybody on this webinar knows about the new updated guidelines and where to find them, but they do supersede the old guidelines. So any hard copies of those 2010 guidelines you have, in theory, we should be pulping them and throwing them away. The new guidelines are available online through the Stroke Foundation website under their Inform Me website, and you can see a screenshot of that on your screens at the moment. You click on that guidelines box and it takes you through. I'm not going to I could spend 40 minutes taking you through the guidelines and how they're structured, which I won't do, but just to remind you that they are published in 8 different chapters. We have tried to link across the chapters where we can, and they're published such that you can get a view of the top level recommendations for any particular topic, and then also be able to drill down through the layers that gives you summaries of the evidence behind that, what the rationale behind that recommendation was. If you're really keen, right down to the data that we extracted from the reviews to inform those recommendations, as well as being able to hyperlink through to full texts of all the articles that were used to form the recommendations. So in comparison to the previous 2010 guidelines, there's a lot more depth of information where people want to go in and see how those recommendations have been formed. But you can also just get that top level bird's eye view as well. The other thing I always like to stress, no matter whatever opportunity I get to talk about the guidelines, is to understand that the new system with the weak and strong recommendations is different. So the recommendations aren't based on the level 1, 2, 3 or ABC of the previous guidelines. We've used the newest international standards for guideline development, which is using the grade methodology, which means the recommendations now come for or against something and weak or strong. And what that means, it's the reflection of the strength of the evidence behind that recommendation. So a weak recommendation doesn't mean it shouldn't be done. It means that it absolutely should be done, but that the strength of the evidence behind that isn't as strong as it would be for a strong recommendation. And on balance, it's possible that another big trial in that same area may mean that the recommendation would be changed. But what a weak recommendation means is based on our current best evidence, this particular intervention should be provided. If the evidence wasn't there, then there'd either be no recommendation or a practice point. And I'm happy to clarify any of that if needs be at the end. That's where to find the guidelines. I'm only going to focus on really the guidelines as it pertains to the amount of rehab in this presentation. And I wanted to talk about these in a little more detail to highlight to you what the evidence is behind these recommendations and why we've made them. It's probably one of the bigger changes in these guidelines that the recommendations are that a lot more therapy is provided compared to the 2010 guidelines. So what you can see on your screen now is a screenshot of the guidelines and the 3 key recommendations around amount of rehabilitation. In this section, we're talking predominantly about motor rehabilitation. We separated out these recommendations into how much scheduled therapy should be provided versus how much active therapy should be provided. And hopefully the reason for that will become clear as I talk further. The main reason for that is because we know that a therapy session, a scheduled physiotherapy appointment, occupational therapy appointment, time with a therapist is not all about active motor practice. There's a lot of what goes on in therapy that's extremely valuable that's not just motor practice. So scheduled therapy doesn't equal active practice time, and those two things are quite different. The first recommendation, and it's a strong one, is that rehabilitation, and we're talking rehabilitation from the time of stroke, not when they hit a rehab centre, but for stroke survivors, rehabilitation should be structured to provide as much scheduled therapy as possible. And the second dot point under that strong recommendation is for the use of group circuit class therapy as a means of providing increased scheduled therapy time. The practice statement underneath that is some further suggestions about how increased therapy time can be provided. And the reason why it's a practice statement is because the level of evidence for these things is less clear, so we couldn't make a specific recommendation about it. The new separate recommendation that hasn't appeared before is around the actual amount of time, and that recommendation is suggesting that we need to be providing a minimum of 3 hours a day of scheduled therapy, with at least 2 hours of that being active task practice. So how do we come up with these recommendations and what are they based on? And then I'll talk more about circuit class therapy in particular. So when it comes to the first recommendations about the amount of rehab, if you're online and in the guidelines and you clicked on the tab that you can see there in grey that says view more details, you will then get a drop-down box to get some further information. And one of the things you'll see is what is now on your screen below that, which is overall what are the benefits and harms and what's the summary of the reason behind this recommendation. And this recommendation was based on consistent evidence from systematic reviews, as well as a meta-regression paper that looked at all the different small trials that had compared different amounts of therapy time for improving walking ability and arm function in particular. And those systematic reviews and meta-regression have consistently shown a benefit from increased therapy time, and that's scheduled therapy time, not necessarily active task practice. But what, for the most part in those reviews, is unclear is the actual amount of time. So from the strength of the recommendation to say as much as possible comes from the consistent findings of several systematic reviews and several small trials, that more is better. As an example, here is a snapshot of one of the more recent ones, and this one came out just in time for us to incorporate the information into this updated guideline. And this starts to go to understand the amount of extra practice question as well. This was a review published just last year in the Journal of Physiotherapy, but it was about the increased amount of usual rehab. And it included both physiotherapy and occupational therapy trials. But what you can see from this forest plot in particular is that when you separate out the trials that have compared one amount of therapy to a little bit more, there's not a lot of difference. When you look at those trials that included a large increase in practice time, this is actual practice time, not just scheduled therapy, that's when you start to see a more consistent message about the benefit. So that's why the recommendation says as much as possible. What's important to note here, and it's a real challenge for us, is a lot of the amount of active practice that even these studies that have big differences include is still probably a lot lower than what's provided in a lot of the animal studies about what we know in terms of driving neuroplasticity. So it's possible that a lot of the increased therapy time is potentially still suboptimal, but we don't know that for sure. So where did our 3 hours a day and 2 hours a day recommendation come from? In terms of the scheduled therapy time, the minimum of 3 hours a day was drawn out of information, particularly in the Lowe's 2014 meta-regression analysis. So again, like I said, this is a weak recommendation because it's not super strong evidence behind it. But we really wanted in these guidelines to give a target amount. So rather than just say more is better, what is really meant by more? So our best available evidence, incomplete as it is that we should be aiming for 3 hours a day of scheduled therapy. But what's important to remember, as I've sort of highlighted in red underline in the next bit, and this is text, as I said, that came straight out of the clinical current guidelines, therapy time is a poor proxy for the actual amount of time spent in active task practice, because therapy is more than just active task practice. But if we look back at the Schneider review as well, that showed that differentiation in the benefit for increased therapy time, the suggestion is that we need at least 240% more. More than what? Or more than what is being averagely provided based on current evidence. So based on our best knowledge, that's equating to about an average of 2 hours a day of active motor training. That's probably still a lot less than what many people are getting, and the challenge becomes, how do we then know what our patients are getting to be able to audit where they sit in that target range? Because as therapists and as healthcare providers, it's very difficult to accurately estimate what our patients are doing. But the important thing is we need to try to focus on that and think about not only what time they're spending with a therapist, but what are they doing with that time. The cut and paste text at the bottom is another piece from the guidelines that advises people that we should be thinking about how we can best measure and monitor that time. And a couple of things around ways to do that. Our traditional ways of doing that have been doing behavioural mapping, so observational days, using video recording of therapy sessions and then analysing what is happening. Of course, these are very labour intensive, and unless you've got some handy free student labour to do, it's very hard. There's more interest in the potential these days of activity monitors to be able to give us some of that information. Of course, they are not designed for use with people with mobility deficits, and they have some pros and cons. But I think this is going to be a space that will increase in our knowledge about how useful these things are, both for monitoring activity and then for promoting activity. So we've just published a review, so the protocol's online for a Cochrane review that's about the use of activity monitors to promote physical activity, not just measure it. The full text of the final review should be online any day now with Cochrane. It's been accepted. The bottom line, as a sneak preview of that review, is that at this stage, there's only been a few studies, and at this stage, they haven't shown great benefit from using activity monitors to promote physical activity. But since we finished that review, we know of at least 3 or 4 other studies that have been registered and are ongoing. So I think this is going to be a very new space. The take-home message really that I want you to take home from this webinar about that is around the target of 3 hours of scheduled therapy, 2 hours of active practice, and how can you and your workplaces feasibly estimate time that people have spent in active practice. So I wanted to go on and tell you a little bit more about circuit class therapy and why it's mentioned in the guidelines as a recommendation for increasing scheduled therapy time. And you'll also see it appears later in the guidelines under the section around improving walking ability. And I'll tell you more for that reason as well as we go through. For those of you who haven't heard the term circuit class therapy, it's, in a nutshell, it's a model of providing therapy. Most of the research has been in physiotherapy, but there have been upper limb trials and upper limb circuit classes that have been provided by occupational therapy or a mixture. And there was some early work around multidisciplinary circuit classes that would be worth pursuing if anyone got interest in that area as well. But essentially, it's a model of service delivery that says instead of having one appointment with your physio once or twice a day and the physio sees one patient at a time, can we be seeing more people at once with a lower staff to patient ratio? And the model is such that it tries to promote more practice time, more active task practice time with more patients per one therapist, and it can be set up in a multiple different ways, whether that be workstations around the room that people like, more like a traditional gym circuit, or more like a group of inpatients in the gym at the one time doing their own individualised program, but in that group setting with a therapist sharing their time between people. There are a range of models, different models of providing it. What I thought I'd just share with you briefly is some of the messages that came out of our circuit trial when we did that trial a few years ago, particularly as it pertains to what's in the recommendations at the moment. So we ran a multi-centre clinical trial quite a few years ago that looked at comparing for people who had gone to an inpatient rehab facility, so the trial was run in inpatient rehab facilities, people who were eligible, who were generally in that moderate FIM band, either continued to receive usual care 5 days a week, predominantly one-on-one therapy, or they received extra weekend therapy, or the third arm was the group circuit class therapy. The results have been published in a couple of papers. The one at the bottom is the main results paper in the International Journal of Stroke, and the results around therapy time come up on the next slide. That they were published the year before in the Journal of Stroke. But just to give you a bit more sense of what we did, so I said the usual care was predominantly provided on a one therapist to one patient ratio, 5 days a week, 7 days a week, self-explanatory. And in the group circuit class, once people were enrolled in the trial, which was within the first few days of their admission to rehab, they no longer received any individual one-on-one sessions with a therapist. Instead, they received group circuit class therapy twice a day for 2 90-minute sessions. That was what the protocol was aiming for. But importantly, we also recorded what actually happened. So we asked therapists to record the actual duration and to some degree the content of every therapy session. In the end then, we had quite a lot of information about therapy time in particular. So from the therapy data forms, We had recordings from over 7,000 individual therapy sessions that occurred within that trial. So we've got some good data to show that those people who are randomised to the circuit class arm of the trial over a 4-week period received an extra 22 hours of therapy time. Now, it's also important to say that there was no extra staffing for the circuit classes. So they were provided within the usual staffing mix and staffing resources of the centre that the trial was running in. By comparison, giving weekend therapy, so both Saturday and Sunday therapy for people in that arm of the trial, those people got on average an extra 3 hours of therapy over 4 weeks. So that's where the strong recommendation behind using circuit class therapy as a means of increasing scheduled therapy time, because we know from this trial that we showed a very big difference in the amount of time that people spent with a therapist. Now, what's important to also drill down into is highlighting again why scheduled therapy time doesn't necessarily equate to increased active therapy time. So I'm not going to go into detail about the results of the trial, but of those of you who know it will know that we didn't show any difference in the amount of walking recovery that people got. There was no between group difference in our primary outcome measure of the 6-minute walk test at 4 weeks, despite the fact that they got an extra 22 hours of therapy time. And of course, that was very disappointing to us at the time. Fortunately, we did do some of these more in-depth analysis of what actually happened during those therapy sessions. So, it wasn't that many years ago we ran that trial, but we were still pretty old school and used a video camera that looked very much like the one on the screen. But we videoed almost 80 physiotherapy sessions in their entirety, and a series of honours students and vacation scholarship students did some in-depth analysis of that video footage and can tell us exactly what happened in the sessions. If you look at these two bars, the height of the bars represents the overall time. So the usual care, the UC bar, on average our usual care physio sessions were a bit over half an hour, and on average our circuit class therapy sessions were around 75 to 80 minutes. You can see by those coloured bars that actually what happened in the therapy sessions was the same sort of stuff. But when you then drill down to the actual time spent in each, the longer time in the circuit class therapy session was made up of more time mostly spent in activities and sitting and lying. That in fact the time that people spent practicing walking was almost to the minute exactly the same if they were in a 30-minute individual therapy session or a 90-minute circuit class therapy session. So what we failed to be able to do in this trial in the rehab setting was get more walking practice time through the use of circuit class therapy. So if walking practice is the thing that you are aiming for with your patients, then just giving circuit class therapy with no monitoring of how much extra walking practice time they get within that is not likely to be effective. And it holds true to what we know about all our principles about recovery. Whatever it is you need to learn to get better at, you need to practice that thing a lot more. So why then have we got a recommendation around the use of circuit class therapy for improving walking ability if in the circuit trial we showed that it didn't make any difference? The reason for that is based on a Cochrane review where there's been a lot more circuit class therapy trials, predominantly in outpatient settings for people later after stroke, that have had a much stronger focus on walking ability and have compared the amount of walking practice you can get in circuit classes in that setting versus usual care, or sham therapy, which is often upper limb related. The evidence in the guidelines is based on a 2010 review, which we updated just last year. So there's we haven't updated the references in the guidelines because overall the recommendation is still the same. It's just stronger evidence for the same recommendation now. So they're actually now, in the previous update of the Cochrane review, we could include 17 trials that looked at circuit class therapy that aimed to improve walking ability. But you'll see that most of them were done with people later after stroke. So there were a handful done very early, a few more done within 3 months, but 8 of the 17 trials with people who were more than a year after stroke. And for all of them, almost all of them, there were people who could walk already, and it was about improving their walking ability, improving how far, how fast they could walk and their balance. Whereas in the circuit trial, we were looking at people earlier after stroke, we had a greater mix of participants, including people who were non-ambulatory to start with. But if we look at the results from the Cochrane review in terms of the impact on improving people's 6-minute walk test difference, you can see a really clear message that the circuit class therapy can improve people's walking ability. In terms of the size of the effect, if we're grouping those trials that were done early after stroke up to 3 months, we're looking at about a 46-metre difference, which is on the lower end of what's clinically meaningful in this measure. Whereas in the trials that included people later after stroke, that difference was just over 70 metres, which is a very robustly clinically meaningful change, to put it awkwardly phrased. And overall, the estimated difference was 60 metres. So that says that for people who, if we kind of put a bit of a summary layer over that, particularly for people who can at least walk 10 metres even with walking aids and some assistance, using circuit class therapy as a way of increasing walking practice and focused on walking activities is effective at improving walking ability. What about, though, stepping back to that earlier stage, the earlier phase after stroke, and the impact of circuit class therapy on length of stay? So actually, even in our updated systematic review, only 2 inpatient trials that have looked at this, one done in Melbourne a long time ago, and ours, our circuit trial, pulling them together, it looks like there is a difference with the idea that providing circuit class therapy during inpatient rehabilitation may reduce people's length of stay. We do have to say, to be conscious of the fact that the really lovely RCT that Jeanette Lederhassett and Wayne Dyett, and I happen to see, I think Wayne's online, showed that the reduction in length of stay in their trial was done 14 years ago. So, and rehab settings and the profile of the sort of patients going through inpatient rehab these days is changing, as is our average length of stay. But we did look at this a little bit more closely. So first of all, actually, here is the data that came from just from the circuit trial, looking at length of stay, comparing the usual care, the 7-day arm and the circuit class arm. You can see for the size of those standard deviation bars that there is, which we all know clinically, there's a great variation in length of stay in hospital and a whole range of things that impact on that. And someone's walking ability is only one small part of what impacts on how long they need to be in hospital for. If you look at the mean difference in length of stay between our usual care arm and our circuit class arm, there was a 9-day difference, which is large, but there's the variation in that data meant that it wasn't statistically significant. But I continue to be very curious about this. So we did another regression analysis, and this, apart from in a conference abstract, we haven't published in the full version. But what we did do is then go back and look at the data a little bit more and think about, of the data that we had within that trial, what else could have impacted on length of stay that we could control for. And when we controlled for all other variables that we could, people who were in the circuit class therapy of the arm were more likely to have a shorter length of stay, and that was in the ballpark of about 12-day difference. But the regression model only accounts for less than 40% of the variance. So to put that in non-statistical speak, that basically means that, yes, there's a chance to have a shorter length of stay if you get circuit class therapy, but there's so many other things that influence it as well. It's only the type of therapy you get is only a small influencer on that length of stay. Okay. So I'm going to change tack a little bit and move away from the amount of task practice story and a little bit more into the physical activity story. And that's where my research these days is a little more focused. And it's important just to get some terminology under our belt to start with. So at any point in time in the day, we are either sitting, so many of you might be sitting in front of your computer at the moment and being sedentary, or you're going for a run at the other end of the spectrum and you're getting your heart rate up, or you're going to the gym. And in the middle, you're doing something else, which is generally light intensity activity. So it could be what I'm currently doing in my office at the moment, pacing around a little bit, standing up. It could be walking to and from the wards, could be walking to catch a bus, pottering around your house. That's that light intensity activity. At any point in time, we're doing one of these things, or what we're doing can be classified into one of these areas. Why is thinking about physical activity important for people after stroke? I'm sure many of you know already that not getting enough physical activity, and particularly not getting enough of that moderate to vigorous physical activity, that huffing and puffing physical activity, not getting enough of that is a major risk factor for first stroke, one of the highest risk factors, and one of the highest risk factors for recurrent stroke as well. So we have an unmet need of how we can help people reduce their risk of recurrent stroke by increasing their physical activity levels. In fact, there was a secondary analysis of a large trial published last year that showed that how physically active somebody was a stronger independent predictor of having another stroke than either blood pressure or cholesterol. And yet we're not doing much to address this in our patients. So, for example, those people in that trial who had optimal medical management of all of their other risk factors, but who were inactive, who weren't getting enough huffing and puffing exercise, were 6 times more likely to have another stroke. So this is why it's something we need to be focused on. This next slide is put in there to give you a sense of the interrelationship between the huffing and puffing exercise and the idea of sitting less. So you would have all heard about sitting's bad for your health, it's the new smoking, go buy a standing desk. And so you're aware of this idea that we're starting to understand more about the effects of sitting time, in addition to what we've known for a long time about the need to have some more moderate to vigorous physical activity. But this graph from a paper published in the Lancet a couple of years ago now highlights the interrelationship between the two. It's not one's independent of the other, there's a relationship going on. And if I can just talk you through this, if you look at the far left of the screen, that grouping of red dots are all people who are super active. So people who are going for an hour run most days, that sort of level of activity. In that group of people, whether or not you start at the very far left, they're people who sit less than 4 hours a day. If you go 4 dots in where it goes up slightly higher, they're the people who sit more than 8 hours a day. Your sitting time doesn't really impact on your mortality and cardiovascular disease risk that much if you go for a run for an hour every single day. So I draw your attention to the last 4 dots on the slide, and the last 2 in particular that are circled in red. That group of people are those people who don't get much huffing and puffing exercise, who spend less than 5 minutes a day in that MVPA end of the spectrum. In that group, even if they're not sitting very much at all, they're still at higher risk of cardiovascular disease and all-cause mortality. But as soon as their sitting time increases as well, that risk exponentially increases. And we know from work that I've done, but lots of other people around the world have shown similar things as well, that our stroke survivors fit into those top 2 categories. So this is a group that are not only not very physically active, but are also sitting a lot and are particularly vulnerable to the effects of sitting time. So if we think about how we spend our day, this pie chart is based on data from healthy Australian adults, where their physical activity was measured with an accelerometer. And most of us healthy adults, and I think if you reflect on what you've done in the last week even, let alone just today, of how active you've been, we're generally spending, even if we're meeting the guidelines, only about 5% of our day in huffing and puffing exercise. The rest of our waking hours is spent either sitting down or in that light intensity activity. And if we look at that same picture for stroke, and this is based on some of my data, it's even a more striking picture, where very, very few stroke survivors are getting any moderate to vigorous physical activity and spending a lot of their day sitting down. So we know that MVPA, that huffing and puffing exercise, we can equate to being a potent drug. It's very effective at reducing your cardiovascular disease risk if only you could take more of it, if only we could find ways to deliver it more effectively. But it's possible that reducing sitting time and replacing some of that sitting time with light intensity activity may also have some effects that are probably going to be weaker, but are probably also going to be important. So that's where more of my research is focused as well. is understanding that sedentary behaviour end of the spectrum. But if we think about this exercise pill, that potent drug, how can we increase how much MVPA, how much huffing and puffing exercise our patients are doing? There's been a lot of work in that, and we need to continue to work in that space, but what the message that's coming out, and it was highlighted by this trial that only came out a few months ago from Norway, is that if we're just coaching people, and this was a trial of 380 people that got monthly, individualised, personalised coaching, goal setting, motivational interviewing about how people can get more physically active after stroke, and they found very little change in either their physical activity levels or the outcomes that they measured. 2 reviews were published late last year that pulled together all of the trials that have been done around promoting exercise after stroke, and the take-home messages from both of those reviews was that regular exercise only works if your people are actually increasing it, and that only those trials that included both the self-management coaching component as well as supervised structured exercise sessions for people showed effectiveness in improving activity and ultimately in reducing cardiovascular disease and stroke risk factors. So we know it's difficult to have stroke survivors take this exercise pill, otherwise we wouldn't have this problem. It's hard enough for any of us to get the amount of exercise that we need, and it's not just about motivating our stroke survivors to do more, it's about enabling them and giving them the tools that they need to do that. And what it appears is that just that self-management and encouragement isn't enough. We need to be finding ways to give them structured exercise sessions that are supervised. But of course, we don't have that system in Australia for our stroke survivors. It's there for cardiac rehab and for pulmonary rehab, but we don't have it for stroke. Sorry, I keep missing where I need to click here. So this is one area that my future work and current work is focused on, is how can we enable stroke survivors to have more of that stronger, potent exercise pill. We have applied for a large grant to look at this, building on our network of activity researchers in stroke known as Actions. And we're proposing a trial that combines both telehealth delivered supervised exercise sessions plus or minus dietary advice as well, because of the evidence around Mediterranean diet for reducing stroke risk. The woman up the top, headshot Emily Ramage, is coming on board as a PhD student very soon, who's going to be starting to pilot the physical activity arm of this trial. And the vision for this trial is that we want to be recruiting people soon after stroke to then be followed up around 3 months and recruited into the trial at around that point. And then we will be providing supervised exercise sessions for people in their own homes via telehealth, with a main telehealth hub out of Newcastle. So that means that we can be recruiting from hospitals in Hobart, in WA, in Darwin, and if people are being discharged home to Taree or Burnie or Warrnambool, that they can still have supervised exercise sessions. They don't have to go into a centre. It'll all be via telehealth. So that's something I'm really keen to hear what people's ideas are about that and what level of support and interest there is from sites around that trial as we go forward. The other thing that we are focusing on in my research group is the other end of the spectrum around sedentary behaviour and trying to get more data about what the impact of long periods of sitting is on people's health, as well as the potential benefits of breaking up sitting time with some frequent activity breaks. So I won't spend a lot of time on this slide. This is just to say that this is some of the data we got from our observational study about stroke and healthy controls, about just how much people are sitting after stroke. A whole bunch of other studies in other disease groups have shown the benefits of regular breaks in sitting time, particularly on postprandial glucose control. So that is how much your blood glucose spikes after a meal. If you're sitting all day, you get big swings in glucose. If you're getting up and moving more often, then those glucose spikes are attenuated, and that's important for endothelial shear. So, but nobody had ever looked at it in stroke before. We've just done the royal we. Paul Mackey, one of my PhD students, and Ashanka, who's an RA in our team, have been working on a scoping review to really pull together all the evidence around these sort of paradigms and what we know about long periods of sitting before compared to breaking it up. And in a nutshell, there's about 20 trials in different population groups, and many of them have shown benefits in terms of glucose control, and a few have also looked at blood pressure and shown reductions in blood pressure with regular breaks in sitting time. So we conducted the first study that's ever been done in stroke on this, and the two papers that have come out of it are under final review with a couple of journals, so they'll be out very soon. But we essentially wanted to look at a very tightly controlled laboratory-based study to look at the effects of regular breaks in sitting time. And running out of time, so I won't go into a huge amount of detail from the protocol, and I'll cut to the chase. But essentially everybody who entered the trial did all three conditions in randomised order, and they spent one day doing uninterrupted sitting. They spent another day where every 30 minutes they would get up and do active standing breaks, so they would do 3 minutes of calf raises, marching on the spot, and mini squats. And on the third day, they would get up every half an hour and do 3 minutes of walking. And those activity breaks were light intensity. We're asking people to work quite lightly. And we measured very tightly their blood pressure, and took bloods regularly, controlled all of their meals so that we could look at the differences in glucose control across the day. The take-home message was that in our sample, we didn't see any significant differences in terms of glucose control. So there's something different physiologically, it seems, in stroke survivors than there is in the other population groups. So that's something that was surprising, and we're still trying to understand. But we did see a significant difference in terms of blood pressure, which was one of our secondary measures in this trial. So we found that people who got up regularly through the day, particularly on the days that they did the standing breaks, their systolic blood pressure remained consistently lower across the day. And what was particularly interesting about that was that, so here's our absolute difference, a reduction of about 3.5 millimetres of mercury across the day on a day that people were doing the standing breaks, and a smaller drop on the walking breaks. What was particularly interesting was that remained the same as type of effect, whether or not people were on antihypertensives. Now, this is a really classic example to show you that these are all people who were stroke survivors, and you would expect most of them to be on antihypertensive medications, or a community sample, but only about half were. Actually, less than half were. So that's a message about, even though these people are meant to be having optimal medical management, there are probably people who are not taking the medications they should be. So regardless of whether people are on medications or not, they still saw a benefit compared to sitting all day with taking regular activity breaks. So this is a story we're pursuing a little more in the next study, and Paul's work is looking at, well, it's all very well if you get up every 3 minutes, every half an hour, that's good for you, but is that really feasible all day, every day in someone's life? Can we get a better idea of what dose, what amount of increased standing activity during a day might have the benefit on blood pressure? So Paul's doing a dose-finding study at the moment to look at that. I'm going to wrap it up there. I was going to talk a bit more about international perspectives of what's happening, but I can allude to that in the questions if you like. I just will then flick through, and I'll skip through that stuff for now, and wanted to acknowledge the fantastic team that I work with up here and across the nation in the work that I do, and the different funding sources that have supported some of the work as well. And a last short plug as well for an online course that I run for clinicians across the board. It's not stroke specific, it's about increasing people's evidence-based practice literacy in terms of being able to quickly turn a clinical question into a searchable one and gather the research evidence behind it. That's a quick little shameless plug at the end as well. I will say that's the end of what I wanted to formally present, and happy to start discussions. I haven't seen on my screen any questions that have come through. I don't know about you, Edwina.
No, there's certainly been no questions that have come through from our end. But we will do a plug for the online course or the course through the Clinical Network's newsletter.
Okay, great.
If you're happy to.
Yeah, absolutely, yeah. So perhaps while people are thinking about questions on more of the content, I will just flick back to saying, just briefly around the international perspective, that there's been we had our first big international roundtable about how we can push forward our agenda of getting better and more research and breakthroughs in the area of stroke recovery. This was a multidisciplinary roundtable, and there's going to be that was 2 years ago in Philadelphia, and there'll be another one later this year attached to the WSO in Montreal. The idea behind this roundtable is that we need to be working together internationally to address these big questions. And what came out of that roundtable was a series of consensus papers that were published in one particular issue of IJS that I really recommend people have a look at. One or more of them, whatever might interest them, but there was a paper around agreed definitions and agreed timeframes, stuff around preclinical work, stuff around how we better develop and report the types of interventions that we provide, where we can move the field forward in terms of biomarkers of recovery, how we can help to better understand why some people recover better than others. And the one that I was involved with, that's my particular passion, is around standardised measurement using common outcome measures in our stroke recovery research. And that was based on the fact that we have more outcomes than trials. And that's not a joke, that's true. Just based on some data out of the VISTA database, which is now quite old, there are very few common outcome measures across trials. So there's no perfect outcome measure, but we should all be starting to think about, in the research land at least, using similar outcome measures so we can pool our data and use our research resources more wisely. So for anybody involved in any sort of data collection, particularly if it's specifically research focused, I really urge you to read that particular roundtable paper and get on board around using our core outcome data set so we can better pool our research data in the future. I think there's a few questions coming in. Would you like me to just fill some, Edwina?
If you're happy to, that's great.
So we got a question about the intensity of rehab for people in community rehab. And the intensity question becomes the same, and it's more about the time frame, I think. There isn't any, taking a step back again, the most evidence we have for the amount of therapy comes from trials which have compared a certain amount of therapy, usual care, to extra practice doing something. So if it's an upper limb trial, it'll be usual care versus extra upper limb therapy, and the extra upper limb therapy almost always shows benefit. So it is whatever somebody's main issues are, providing as much therapy as possible. But we don't have any hard and fast guidelines. I think the 2 hours a day of active task practice is still a good one to aim for. Now, of course, that's not going to be with them coming to community rehab settings every day. That sort of amount of practice where people are trying to get gains in motor function is important. And that holds true for things like constraint-induced movement therapy as well. As a particular example, we know that that's most effective when it's coupled with very intensive task practice. And in terms of acute care, is this level of activity recommended in acute care as well? I think I'm glad somebody raised that, because I think it's important to also look, when you're working with people very early after stroke, to also look at when should rehab start, and the results around the AVERT trial, which I didn't put into this presentation. But for those of you working in acute will know that trial showed that getting people up too early, particularly if they have a severe stroke, is probably harmful. But when you look at the in-depth analysis of the dose-response relationship for people who are not at that very severe end, a little bit and often seems to show the greatest benefit. There is more work happening. There's a new AVERT trial that's going to be starting that's trying to understand that dose in more detail. But the take-home for now, based on the guidelines, is getting people up after 24 hours, but as soon as possible after 24 hours, and getting people moving frequently and often is the most important thing in those first few days. Hopefully that answered that question. And there was another one around medical screening before commencing circuit class training. I think when we're looking at getting somebody to exercise and get their heart rate up when you're aiming for certain heart rate targets because you're trying to get more moderate to vigorous physical activity, That's when there is ongoing debate about whether it's absolutely necessary to get medical screening, but that's where it's probably prudent to do that if you're concerned. So certainly the trials that we do here, current PhD student doing that telehealth trial of exercise in people's homes, we always do get GP clearance for that. And we haven't had anybody knocked back for medical clearance, but it does just give a bit more confidence that this is safe for people when you're really pushing their heart rates up a little bit. If it comes to circuit classes as a model of increasing scheduled therapy time and in terms of improving somebody's motor function, walking practice or upper limb practice or standing balance, there's no need to get medical clearance for that. In my opinion, it is just another model of providing normal physiotherapy or occupational therapy services. So I would say that you don't need medical clearance for circuit classes in that respect. And Wayne's comment, very pertinent. It's very difficult to get clinicians to do it. And it's not so much to get, I would just reword that little, Wayne. It's very difficult often to translate guidelines into practice and to change what's usually done and to find ways to work within a system that's not always flexible to encourage implementation of guidelines. Absolutely, translation to practice is the biggest thing. And the Stroke Foundation are now working on getting more resources to support people in that, and it is a big focus of what we're trying to do. And I think it is important for us to understand some of those reasons. I think we know a lot about what some of those barriers are. What's now important is to think about how we can help to address those barriers and enable workplaces and people to get more of that practice time happening, because it's not that people don't necessarily want to, it's how we can do that more effectively.
That was going to be my question for you, Coralie. So obviously you've presented some really great information, but what's your take-home message for clinicians who are wanting to implement increased intensity of therapy through circuit classes in their health services? What are some of the key take-home messages or key things that they should be considering?
I think they can. I mean, I can do I can do and have done lots of workshops on practical ways of how to get started in doing circuit classes. I think probably the short, quick take-home message is give it a go, start small. So start with not aiming for a circuit class that everybody goes to every day and has 6 to 8 people and one therapist. Start much smaller than that, that's a little more achievable, and build from there. There are all sorts of tips and tricks about how you can get started, how you can plan circuit classes, what sort of space is most useful to set up a circuit class in. Talking to people who have done them, and there's lots of people around Australia who are doing them in practice. So if it's something that your workplace isn't doing, trying to find out what places are doing them more and going to visit and chat to people who are doing them on a daily basis to get some of those really practical suggestions of what works. And the Stroke Foundation, I know, are going to be working on a education package, particularly around circuit class therapy, that people might be able to tap into as well.
And do you happen to know off the top of your head perhaps some services in Victoria that are doing it particularly well?
So I know Royal Talbot were, and if Wayne's still online, he might be able to type us a response to know if they're still doing circuit classes there. And at the time of the circuit trial, we were running them at the Parkville campus of Royal Melbourne. There was another name for it as well that I can't remember off the top of my head. I'm not sure if they are continuing to do that. So no, they're the only two that spring to mind at the moment, because I've not worked myself a lot in Melbourne clinically. So I'm hoping others on the network might be able to. Wayne has. Wayne says, happy for people to come out to Royal Talbot to watch our circuit class. And Sharon F. Peninsula Health runs stroke circuit groups 3 times a week for outpatients and daily upper limb circuit classes for inpatients. There are people out there. A few times I've tried to get a Facebook group going around clinicians who are using circuit classes to help each other. and I think that's still there. It's just not very used. That if there's an interest in that, I can reinvent that. I know there's a couple of places in Sydney who are doing a lot with circuit classes as well, because I think that's how you learn to run things. You learn what the common pitfalls and common successes are in rehab centres or acute wards that are similar to your own.
And so if anybody in particular would like to get in contact with me, I'm happy to investigate this further and get them in touch with people from any of these services that we've mentioned. I think it is probably interesting also to note which services do physio only and which are combined physio OT.
Yeah. And I know in South Australia, Hampstead Rehab still do a lot of circuit classes as well. And if there was interest in running a more practical workshop, I'd be happy to organise coming down to doing that for the Vic Stroke Network as well, if there's that interest.
Great, thank you. Are there any more questions?
Somebody else, Sarah C, said Caulfield Hospital does circuits as well. Which I should have remembered, of course.
Thank you again, Coralie, for taking the time to present to us this afternoon. I think everyone will agree that it's been a fabulous presentation, and I think that it's really clinically applicable and certainly really important for clinicians to be incorporating as part of their practice. I think your presentation also leads quite well into the next presentation, which is scheduled on the 23rd of July at 3 p.m. And Bruce Campbell will be presenting on the updated clinical guidelines. So the link is available on the Better Care Victoria website, and if anybody needs me to send that through again, just contact me via email. So if I think there's nothing else, then we can finish the presentation for today, and thanks once again, Coralie.
Thanks very much.